very good morning to Dr. Aloysius Joseph Low, Chief Consultant Ophthalmologist, Cataract and Refractive Surgeon, Vista Eye Specialist, Dr. Alan Koh, Senior Consultant Ophthalmologist, Cataract and Refractive Surgeon, Vista Eye Specialist, distinguished guests, ladies and gentlemen, welcome to today's StarLIVE session with Vista Eye Specialist. My name is Julianne from Star Media Group, and we're really excited to see everyone here today. Ladies and gentlemen, StarLIVE, presented by Star Media Group, is a talk series that covers various topical matters of interest, from guides to leading a healthier lifestyle to meet and greet sessions with personalities. It is one of our ways of connecting with our readers. Today, our speakers are Dr. Aloysius Joseph Low and Dr. Alan Koh from Vista Eye Specialist, and they'll be clearing up everything there is to know about cataract. At the end of the session, there will be a Q&A opportunity with our guest speakers. Without further ado, please join me in welcoming our first speaker, Dr. Aloysius, who will be shedding light on what cataract really is.
So before we start out what a cataract is, perhaps we have just an understanding of how the eye is. The front part of the eye is called the cornea. That's the clear window. Some of you may have heard about corneal transplant. So corneal transplant of the cornea does not involve the lens. That is the cornea. And behind the cornea is what we call the iris. The iris in this case is a Marsalis iris. It's blue in color, but in Asians it will be brown. And behind the iris is where our natural lens is. Now, our natural lens is transparent. It has a front membrane, which we call it the front capsule, and also a back capsule. So, enveloped between this front capsule and the back capsule is the contents of the cataract, is the contents of the lens. Now, within these contents, it has an inner core, which we call the nucleus, and an outer core, which we call the cortex. When a patient has cataract, it is the lens, the natural lens, that becomes opacified, loses its transparency, and it becomes cloudy. This cloudiness of the lens can involve the contents, which is the nucleus and its cortex, and it can sometimes also involve the front capsule and the back capsule. Now, if we look at the commonest causes of blindness today, and let's just look at Malaysia. Cataract is still the #1 cause of blindness in Malaysia, followed by glaucoma, and then age-related macular degeneration, and diabetes, the 4 commonest causes of blindness in Malaysia. Studies have been done in Malaysia as well as elsewhere, where by the time we are in our 80s, up to 68.3% is known to have cataract. But really, this is a study done in the US. But so far in our practice here, I don't think I've ever seen a person who is past 80 who never have cataract. So actually, everyone has cataract. It's a matter of, as we grow old, if we grow old enough, we will see cataract in every eye. Now, what are the causes of cataract? The main cause of cataract today is aging, age-related. But there are also other causes of cataract besides aging. If we have prolonged use of corticosteroids, whether orally or if we apply in the form of eye drops, prolonged use can also lead to cataract formation. A child can be born with cataract, and that's what we call congenital cataract. And then a growing child, initially, when born, no cataract, but as he grows into adolescent, he can develop cataract also. This is what we call developmental cataract. Systemic diseases like diabetes is another common cause for cataract, especially in the earlier age. You see average Malaysians with cataract and surgery done is about 58 years old. Diabetics, even in their 40s, they can already develop cataract. Then other causes include trauma to the eye, whether it's blunt trauma like a punch directly on the eyeball, or a perforating injury like a nail hitting directly onto the eye, causing a perforation. That itself leads to cataract. People who are born highly short-sighted, they tend to develop cataract at an earlier age, even in the mid to late 40s. And of course, other eye diseases like infection or inflammation can also cause cataract. Now, how does the patient complain when he has cataract? What does he complain? The symptoms and the signs. Most of these complaints are related to the vision. Vision, as we must see it today, is most of us associate vision with just looking at distant object. This is called distant vision. But we must not forget, we also have near vision and intermediate vision. Near vision is of course, when we want to read a material or article at 12 inches, that's our near vision. But if we want to, say, play mahjong, or we want to look at the speedometer of our car when we drive, or when we are doing cooking, that is our intermediate vision. And of course, distant vision, there's no brainer. All of us know what is distant vision. So the main thing is, when we have cataract, the most important complaint, or very common complaint, would be blurry vision. Blurry vision, sometimes patient does complain that they see double vision or ghosting. These are all related to blurriness. Some patients complain that their night vision is poor, that their confidence levels, say when they drive last night at night is no problem, but now they have an issue, They feel not so confident to drive because cataract affects your night vision. At night, sometimes they complain of what is called glare and halos. The picture on the left is what we call glare. Halos are rings of light. When we look at a source of light, you see a ring, another ring, or two rings of light around that light source. That's what halos is. Some patients complain of sensitivity to strong lights. They cannot tolerate it. And then don't forget, patients also complain of color vision, colors not being so vibrant. Cataracts affect your color vision. And sometimes also the patient will complain that they have to change their glasses frequently. Now, at our age, if we are short-sighted, most of the time our short-sightedness should be stable already. But if you have to keep changing your glasses every year, then something is not right. And one of the complaints associated with cataract is a frequent change of glasses. So you have cataract. How do we manage it then? In the early stage, sometimes glasses can improve the vision, but glasses doesn't take away your cataract. It just helps you in the early stage. Because the same pair of glasses over the years, then your vision again become blurry, and the glasses is of no use to you. So glasses is not a solution, permanent solution to cataract treatment. Oral medication, some patients say, can I take some medication and get rid of my cataract? No, oral medication like antioxidants does help to slow down your cataract process, but it doesn't remove your cataract. Your cataract still occurs. How about eye drops? Certainly, there are no eye drops in the market today that can melt away your cataract. But there is a company which now starts to sell eye drops in the form of antioxidants. Instead of taking antioxidant orally, they have eye drops that contain antioxidants. Well, this will not remove your cataract, as I said. Antioxidants, in this case, it may delay the need for surgery, but eventually you still need surgery for your cataract. And what we know today, the most effective way of restoring your vision when a person has cataract is still surgery. Now, surgery for cataract has evolved over the centuries. In the first picture on the left, this is what we call couching. Couching is a procedure, a very crude procedure, whereby we use a sharp needle and we press the cataract and push the cataract backwards, and then it drops into the eye, so clearing the impairment. So for a time being, of course, suddenly the patient can see, but it is very painful, and the patient suffers from infection and inflammation, and ultimately the patient becomes blind. So this usually occurs, there is someone who just wants to see the family members before they die, so they don't mind suffering for a while just to see everyone before they pass away. So this type of technique called couching has been before Christ. And then later on comes this procedure called ICCE, or intracapsular cataract extraction, whereby through a big wound, you remove the whole lens, including the front and back capsule and its contents, leaving the eye completely without a lens. This type of procedure, the ICC procedure, was very common when I was a medical student. So what happened is that the eye now is devoid of any lens. So we compensate by making the patient wear very thick glasses. We call them Coke bottle glasses. Because there is no lens inside the eye, so we have to compensate with very thick glasses. And that means the visual field of the patient is constricted. So now a more elegant way, then later on, it comes this procedure we call the extracapsular cataract extraction, or ECCE, whereby they retain part of the lens. That means part of the front capsule, the whole of the back capsule, and we empty the contents of the cataractous lens. And this is done through a big incision. And later on, they put a lens, a big, thick lens, a big lens into the eye. And all this necessitated going through a big incision. This was a much improvement from the ICCE. This ECE method is very common, was very common in Malaysia, and is still practiced by some surgeons today, just a handful of them. And this was very common when I was a medical officer. But remember, it's a big opening, big incision. You need to give injection into the eye in order to make sure the patient is calm enough for you to do the surgery. And you need stitches to close the wound. Then in the 1960s, starting in the US, they came up with this more elegant procedure called phacoemulsification, which is still practiced in Malaysia today. It came to Malaysia in the 1990s. Now here in this procedure, the phacoemulsification is really a mouthful. The incision size is reduced from 10 millimeters in the ECCE days to 4.1 millimeters, some then goes down to 3.5 millimeters. And then to remove the cataract, they use a probe, an ultrasound probe that produces ultrasound energy to break up the contents of the cataract into an emulsate. That's why it's called phacoemulsification. And at the same time, they suck out this emulsate. So because you need ultrasound energy to break up the contents of the cataract, in the process, heat is produced. And this heat sometimes damages the adjacent tissue. So this procedure, I said, is still being used in Malaysia today, phacoemulsification. Now what happened is that when doctors explain to patients about this procedure, phacoemulsification, I say, is such a long word. Most doctors will just use the word laser, the magic word. Easier, patient seems to accept this word better. But really, no laser is involved in phacoemulsification. It is ultrasound energy. So upon this technology, this is what we call blade cataract surgery, using the blade, because you open the wounds using a blade and a sharp instruments. Then we improve on this technology today using the no-blade cataract surgery, where we don't use the blade or sharp instruments to enter into the eye to reach the cataract. We use the laser instead to make the necessary cuts or incisions. So this new technology and technique is what we call no-blade cataract surgery. There are actually 6 major steps involved. The first step is the computer scan the eye. That is the first step. The second step is that the computer now guide the laser, and this is a femtosecond laser, to make the cuts to make the cuts on the cornea, instead of using the metallic blade to cut into the cornea. And the same laser makes an opening in the front capsule of the lens. Otherwise, we will have to use a sharp instrument to make a circular tear as round as we can. But here, when you use a computer to make a circular opening, you tend to get very consistent opening and repeatable. If you want a 5.4 mm round opening, it will always be 5.4 mm. Whereas if you ask me to make an opening with an instrument, that means the surgeon's hand is making the opening, you can't always get a 5.4 mm opening consistently. Sometimes it's bigger, sometimes it's smaller. So the laser makes all the difference. And the laser itself is used, the same femtosecond laser is used to make cuts on the contents of the cataractous lens. So making it easy. Instead of using a lot of ultrasound energy to emulsify the lens, the femtosecond laser has already made the cuts for you. So the amount of ultrasound energy used now is so much reduced, so less heat, less injury to the adjacent tissue of the eye. And finally, once we empty the lens of its contents, we have what we call an empty capsular bag, into which we implant a lens, an artificial lens. If we don't implant any lens into the eye, after we remove the cataract, we are not doing any service to the patient, because the patient can't focus. Then we are more or less like back to the days of ICCE, where the patient has to wear very thick Coke bottle glasses. There's a video here to show you the differences between a femtosecond cataract surgery versus a conventional cataract surgery or the blade surgery.
Using the Zimmer Femto LDV Z8 laser. Cataracts are a clouding of the focusing lens inside your eye. They develop over time and can significantly impair your vision if left untreated. In traditional cataract surgery, incisions into the eye are manually created with a blade. These incisions allow your surgeon to insert the instruments used to remove the vision-blocking cataract. The Zimmer Z8 laser creates these incisions using a beam of laser light, providing very precise and customized incisions with Swiss engineered accuracy. When performing cataract surgery with a blade, a linear incision is typically created. The Zimmer Z8 laser allows for the predictable creation of incisions in a variety of patterns for optimal results. Incisions made with the Zimmer Z8 laser typically heal on their own without the need for sutures. Once an incision has been made through the cornea, The next step is to create an opening in the anterior capsule of the lens, a step traditionally performed by hand. The Zimmer Z8 laser can create this opening in a manner that is much more precise and consistent than is possible with manual techniques. Finally, the cataract is removed using a procedure called phacoemulsification. In traditional surgery, the cataract is removed using multiple passes of the phaco tip through the lens. The Zimmer Z8 uses laser light to pre-fragment the cataract into small segments, making it easier to remove from the eye with less movement of the phaco tip. This could potentially diminish the possibility of the phaco tip damaging surrounding tissue. In addition to its applications for cataract surgery, the Zimmer Z8 laser can be used to create up to 3 arcuate incisions on the surface of the cornea. Rather than cutting these incisions with a blade, the Z8 delivers an incredibly fast sequence of low-energy laser pulses, which form ultra-precise microscopic bubbles at a pre-programmed depth and length to make the incision. The results are precise to within 1/100th of a millimeter. Talk to your doctor about the advanced blade-free procedures offered with the Zimmer Femto LDV Z8.
That machine is the Femtosecond laser machine. Now, so a person has cataract, he has to make decisions. Does he want to choose the blade technique or the no blade technique? Is there a lot of difference? Well, technique-wise, there is a lot of difference. Steps that require the surgeon to manually make the incision or make an opening is being replaced by the high accuracy and precision of the Femtosecond laser. So accuracy and precision translate to safer surgery. Now, so if we use the Femtosecond laser, first, because of precision and accuracy involved in the wound, we expect, and we should expect, and that's the way it goes. It becomes a safer surgery, and the wound heals faster, and you don't really need stitches. Because sometimes when you use the conventional phacoemulsification, you may need 1 stitch. Last time we used up to 7 stitches for the ECCE technique. Here, you may need 1 stitch, or maybe no stitches also. But when you use this femto laser, most of the time, I don't think anybody needs a stitch. So far, we don't have to use it. Then, because we can make very high precision cuts, we can place the lens inside the empty capsular bag very precisely, so that the lens inside the eye doesn't tilt or rotate. Now, remember, as I said, we use the ultrasound to break up the contents of the cataract. The ultrasound works like a jackhammer, and that's why, because of that, heat is produced. Whereas the femtosecond laser, it is so fast. The speed of a femtosecond laser is 10 to the power of minus 15 of a second. Can you imagine? It's so fast that heat is hardly produced. So as a result, you don't see a haze, so much haze in the cornea the next day. So the frequently asked questions is, when must I have my cataract surgery? That's what patients used to ask me. Do I have to wait for the cataract to become matured and hyper-matured? No, you don't have to. Not in today's era, today's practice. In this time and era, no. Maybe during the time of our grandparents, where, as I said, the technology was still crude. Maybe you want to wait. But here, with this type of technology today, there's no need to wait. So when do we need the surgery? As long as you feel that your cataract is troubling your daily lifestyle activities, your confidence level to drive or to enjoy your hobbies is reduced because of cataract, that's enough reason or indication for cataract surgery. But then, again, why do some patients still wait? We know that patients who have cataract, they still wait. Usually, some is the surgeons, some surgeons prefer to wait. They don't want to do cataract surgery when they feel that the cataract is still early. It's the surgeon preference. And sometimes it's the patient's financial status. They have problems searching for money. They wait. They need the children to provide them the finance, so they have to wait. Or certainly, some patients, they prefer to go to government hospitals where there's already a long queue, then they have to wait. But that is because they are forced to wait in a way. But by today's indication practice worldwide, is as long as the cataract troubles or daily lifestyle activities, you can do the surgery already. All right. But the most important thing I'd like to stress here is that you should never be talked into doing cataract surgery if you are not ready mentally. Because we find that when patients are coerced or talked into having cataract surgery when they are not mentally ready, these same patients, even after we have done a good job on their eyes, they are never happy. They have something to complain. They'll find something to complain. That's it. They just want to complain. Just they're not happy from the start. So you must be ready mentally before you do surgery. Don't let people talk you into it. Is there any risk if you delay your surgery? Certainly. As the cataract becomes harder, then the surgery itself becomes harder because the cataract is denser, thick, brunous, and hard. So when we have to deal with a too hard cataract, too mature or hyper-matured cataract, there are challenges and problems. So when this translates to increased risk that happens during the surgery. And let's say the patient is very stubborn, he won't yield to cataract. They're in a state of denial. They refuse to accept that they have cataract, even though we tell them they have cataract. Then what happens is that this cataract will lead to complications like secondary glaucoma. Now, in secondary glaucoma itself means that the disease has attacked the nerve that connects the eye to the brain, and it damages the nerve. And then the patient will have pain and redness. Now, even at that stage, the patient may surrender to cataract surgery, but it's too late. Because even if we remove the cataract at that time, the damage to the nerve is already permanent. So the patient will be blind. And then it's just a convenient time for the patient to blame the cataract surgery again. But they don't blame themselves. That's the problem. Now, we know that if patients can't see, and for those of you who do some charity work, and then you go to this old folks' home, some of them actually have got cataract. They are actually depressed. They can't see. It's near blindness. And we don't blame those working in old folks' home because they don't know anything about cataract. They think it's already, just leave this old folks aside. But they can't see. It's because of the cataract. So cataract can lead to anxiety and finally to blindness. Thank you.
Thank you very much, Dr. Aloysius. Thank you very much, Dr. Aloysius. Kindly take your seat. Ladies and gentlemen, before we introduce our next speaker, we'd like to share with you a video. It will be in Mandarin, but there will also be English subtitles. Please bear with us for a moment.
您是张语言的女儿吗？对。
女儿。妈，你怎么来了？我来看看你。小婶子长这么大了。
你
虽然被婉言拒绝，但张雨莲还是决定去城里照顾女儿。女儿小时候一生病，他就会煲鸡汤给女儿喝。这次，他只想亲手给女儿做顿饭。
妈，哎呦，哎呦，要不我来吧？不是，我来。你拿筷子是吧？我给你拿，来，慢点啊。
妈妈，这小鸡还没死呢。
鱼来了。
哎呦妈，让我来。哎呦，妈赶紧一块儿吃啊。
你吃，你吃。
这顿饭米很硬，菜很咸，难得的团聚，他却只待了1天就走了。女儿一再挽留，但他还是执意离开。女儿觉得有些不对劲，半个月后养好身体回家探亲，才发现了母亲的秘密。
女儿。
张雨莲，63岁，一只眼睛患白内障，接近失明，另一只也严重老化，担心花钱，一直瞒着孩子。为了女儿，他第一次一个人走出大山。他可能看不清路，但他清楚地知道，女儿就在路的那一头。从家里到女儿所在的城市，要翻过2座山头，趟过一条小河，走28公里的山路，要转3次车，跨越4个省，坐36个小时的长途汽车。他对这个城市一无所知，除了知道女儿的名字，一切都是为了给女儿做顿饭。每一个母亲都像张雨莲一样，对自己吝啬，但对孩子可以倾尽所有。世界上最好吃的东西是什么？
We now like to invite up Dr. Alan Koh, who will be sharing with us how one can see without glasses after cataract surgery. May we invite up Dr. Alan Koh.
Okay, good morning, ladies and gentlemen. Okay, just now we heard about what Dr. Aloysius explains about the what is cataracts, the causes of cataract, and also the sign and symptom and the cataract treatment. So, you know that cataract surgery now had 2 important parts. The first part is to remove the cataract or the cloudy lens, either using a traditional blade way or using a no blade laser, the modern type. And the second part is to implant an artificial lens, or we call it the intraocular lens. Okay, intraocular lens is not something new. It's already more than 60 years of history. The first lens, intraocular lens, was implanted in the human eye in 1949. And the lens is a hard lens, and you need a large incision, what Dr. Aloysius explained just now, and it's no longer in use. And in the 80s, the foldable lens were introduced, and less require a smaller incision or surgical wound. The lens, the intraocular lens in the 80s and the 90s is just a basic, or what we call a monofocal IOL, or monofocal lens, where after implantation of the lens, we can see the distance clear, but most of the patients still need glasses to improve their visions. Okay, in the recent year, the monofocal lens slowly evolved into a multifocal lens, either old type or old generation of multifocal, we call the bifocals, and the latest form, the trifocals. All these lenses are available in Malaysia, which can help the patient to see better, to see the distant, intermediate, and near. So with the evolution of the intraocular lens, the cataract surgery already evolved into a refractive surgery. It means that the cataract surgery not only remove your cloudy lens, but it also at the same time can correct your vision, correct your short-sightedness, your long-sightedness, your astigmatism, and your reading visions. And this continued technology advancement on the artificial lens actually make it possible. Okay, before we continue with some the slide, I'd like to play a video on how a modern cataract surgery with the multifocal lens can improve a person's life.
That magnifying glass out once, not once, so I can give them away.
Well, as our bodies age, no doubt, so do our eyes, which means eventually most of us wind up needing glasses or contacts, but there is new technology in West Michigan that's helping patients ditch that eyewear for good. And new tonight, Fox 15's Erica Francis is introducing us to one woman from Grand Rapids who went from using a magnifying glass to read to having perfect 20/20 vision. Erica.
Yeah, Josh, this new state-of-the-art technology can be used to correct aging eyes of laser surgery, affecting the way patients like Peggy Bino will see for the rest of their lives.
And I would be getting out my magnifying lens.
For nearly 20 years, it was hard to find Peggy Bino without her glasses and magnifying lens.
I don't do crossword puzzles anymore because it's too difficult to see the numbers.
For her, it's difficult to see much of anything. She suffers from farsightedness, astigmatism, and a significant cataract.
I have not driven at night for almost 3 years.
As we age, our lenses get harder, eventually turning into cataracts, causing a constant glare or cloudiness in the eye.
No, it's just a blur.
It's common enough that Bino assumed she'd be glued to her glasses for the rest of her life.
But I can't read a word.
Then she met Dr. Snyder from Holland Eye.
The technology we have now is better than it's been, and it keeps getting better.
That technology, a new state-of-the-art laser called Catalyst.
The Pro is glasses in
the lens and break up cataracts while making a small incision in the eye.
It scans the whole eye and creates a 3D map of the eye, and that allows us to know the center of the lens and the center of the visual axis. And then it makes an opening in that lens based on that.
Before they can count to 2, patients like Peggy are ready for cataract surgery to begin.
And then the lens that was lasered into little cubes. The advantage of that is that then I could just suck out the little cubes and use less energy.
This gives extra security and precision, as well as faster healing times.
Half of the cataract is already removed now.
At that point, doctors remove your natural lens and replace it with a 6mm multifocal lens that you see right here. And it's smaller than the tip of my finger.
Doing great, Peggy. Cataract's all out now. We just got to put the lens in next.
Less than 10 minutes later, Dr. Snyder places that new lens in Peggy's eye.
This lens creates 2 images, a near one and a distance one. The side effect of that is that you have some glare and halo at night.
That treatment, combined with a multifocal lens, is letting Peggy ditch her glasses and magnifying lenses for good.
I have not had that magnifying glass out once, not once. So I can give them away.
I was going to say, time to give it away or throw it away.
It is, yeah.
Just a week after laser cataract surgery,
I can even see this line.
The woman who was never seen without her glasses is now
born in the USA,
seeing without them.
Every day it's just pinch yourself. It's so exciting. I don't know that I ever saw this good.
Okay, you can see how amazing a the modern cataract surgery with the multifocal lens can actually make improve patients' quality of life and make patients more happier. Okay, now we ask, a lot of patients ask, so what is the best lens for me, okay, for myself? Important, you must know your needs. You look at your lifestyle, okay, or your hobby. Okay, do you like to travel around? You like outdoor activities? Or you drive a lot at night? And even you like to read your handphone, books, or like to do cooking, play mahjong. All this is important. You need to let a doctor know so that the doctor can tailor the need, okay? And the second one, and you have to know that what kind of vision do you want, okay? You want a clear distant vision, you want a clear intermediate vision, you want a clear near vision, or you want all the visions, okay? And the last, very important, you have to ask yourself, do you willing to wear reading glasses after the surgery? Okay, may I ask the audience here, do you all like to wear reading glasses? Can you just hand up? Who don't like to wear reading glasses? Just hand up. Okay, can see majority. I can guarantee that most of us don't like to wear reading glasses because it's so inconvenient, clumsy, and make ourselves ugly. Okay, so now with the modern cataract surgery and implantation of a multifocal intraocular lens, we can actually throw away our glasses, and it's permanent. Okay, our eye, our lens, our natural lens, when we are young, before 40, are clear, soft, and flexible. So when we see far, our lens is relaxed stage. You can see clear, but when we try to look near object, our lens actually, our muscles of our eye can actually change the shape of our lens, make it more thicker for us to focus the near. So we have no problem with all distance, all range of distance. But this ability we call accommodations, okay? But when we become older and older, after 40 years old, the ability of accommodation actually reduce, progressively worsens. So now, slowly, you're near, you can't focus for near, your computer, you're near, and eventually you need a reading glasses. This thing we call a presbyopia. Everyone will have a presbyopia. Okay, even worse, when you are getting older, you start to have blurring of vision because you have cataracts. So once you have cataracts, as affecting your daily activity, you have to go for a cataract surgery with the implantation of the artificial lens. Okay, let's say you implant a basic lens, we call the monofocal lens. You will have a very good distant vision, but anything in the intermediate, your near is not clear. You must use reading glasses. And if you use a bifocal lens, which is an older version of multifocal lens, your distance is good, your near is okay, but you lost your intermediate vision. If you need to use computer, then you have to bring the computer nearer, or you need a glasses for intermediate work. And for the most latest lens, the trifocal lens, and after implantation of the trifocal lens, you can see the far clear, intermediate clear, and the near clear. Okay, this is the summary. For the monofocal lens, the traditional lens, you have a good distant vision, no intermediate vision, and no near visions. And in the modern technology with the latest trifocal lens, you have the good distant, intermediate, and near. So your vision can return like as when you are young or 40. Okay, there's some frequent question we ask from the patients. Some patients may ask that, can I change my mind and upgrade to another lens after initial surgery? Actually, this is possible, but as a doctor, usually we don't encourage, okay, we don't recommend, because the first initial surgery is very simple, may take about 10 minutes, and it's very safe. But the surgery to remove a lens which already implanted for a few years or few months is more difficult and involve more risks. Okay, even your vision can be deteriorating after the exchange of the lens. So we don't actually recommend patient to exchange the lens. So you only have we tell patient you only have one chance to choose the best lens for yourself. And some of you all, maybe you have friends or relatives who have done multifocals, multifocal intraocular lens, and some of them will complain they have quite bad night visions. Their vision is not clear. And it's true, this is for the older version of bifocal, because the older version of multifocal only can help you to see the distant and the intermediate and the near. The intermediate is not clear. And for the bifocal, the older version, you need better illuminations, you need a brighter light to help you to see. Okay, and night vision, a lot of them will complain of glare, halo, starburst. But with the newer generations of trifocals, it's actually improved a lot. You can see, you have improved night visions, you have good intermediate visions. And most of our patients, after implant of trifocal, they seldom need any glasses for any range of distance, and they seldom complain of any night visions. Okay, so in summary, the modern cataract surgery is more safer now, and the cataract is not only the modern cataract surgery is not only to remove the cloudy lens, but it's actually do the vision correction. We correct your short-sightedness, your long-sightedness, astig, and we correct your reading visions. Okay, by implanting the trifocal lens, you can enhance your quality of your golden age, and you have more freedom after retirement. Okay, lastly, I like to see that patient decision is the most crucial part of any surgery. As a doctor or medical advisor, we actually provide you information and guidance based on your decision, your condition and need. But the most important, the patient have the final say. Okay. Okay. Thank you.
Thank you very much. Thank you very much, Dr. Allen. And now, may I invite Dr. Aloysius and Dr. Allen up on stage for the Q&A session. Ladies and gentlemen, if you have a question for our guest speakers, please raise your hand and we'll pass you a mic. Please share your name followed by your question.
Hello. Yeah. Good morning, doctors. My question is, what are the chances of cataract recurring after you have done the surgery? And if so, after how long will it reoccur? Thank you.
This is a very common question. My patients ask me always, does a cataract recur? The answer is cataracts never recur. The cataract never reforms. Now, but you have heard some patients say the cataracts, patients say, not the doctor, patients say that the cataract recur. Now, what actually happens is this. Remember, the original lens has got a front capsule and a back capsule. In cataract surgery, we remove part of the front capsule, all the contents within the two capsules, but we leave behind the posterior capsule. So now, essentially, it's an empty capsular bag into which we implant the artificial lens. Now, in 10% of eyes, after 1 year following cataract surgery, this posterior capsule undergoes thickening. In the medical term, we say posterior stands for back, the back capsule versus the front capsule. The back capsule, we call it a posterior capsule in a medical term. We call it this condition called posterior capsular opacification, or PCO. It's what you refer to as so-called second-time cataract. So it's not really a reformation of the original cataract. It is the thickening of this posterior capsule, which is loosely referred at, and it's a wrong term, misnomer really, when people call it secondary cataract. It's not really a reformation cataract, it's this thickening of this posterior capsule. And then what do? To the patient, again, the vision becomes blurry because this thickened capsule can opacify. So what we do is that we take the patient for a YAG laser. This laser is just a 30 seconds job. It's not surgery, it's a laser treatment. YAG laser stands YAG. What this laser does is that it breaks down this thickened membrane. And once this is done, you'll never get again this PCO for the rest of your life. So 10 patients, 10% of eyes undergoes a YAG laser after 1 year of cataract surgery. Now, coming to talk about PCO, not every eye that has this thickening needs this YAG laser. This is something you have to understand. If the thickening occurs in the periphery of this posterior capsule and not in the center of this posterior capsule, you don't need a YAG laser because it won't interfere with your vision. But if this thickening occurs in the central part of this posterior capsule and it interferes with your vision, then only you need the YAG laser. So there was one study in the Philippines. No? They say that after cataract surgery, everyone will develop a thickening of the posterior capsule. Yes, 100%. That's what the small study says. But this PCO rate, we call it, is different from YAG rate. YAG laser rate is different. YAG laser rate is 10%, but PCO rate, according to that small study, is 100% because they see some thickening in every posterior capsule after cataract surgery. But not everyone needs a YAG laser.
Can we have the next question, please? Hold on.
I'm Peter Chan. I have 3 questions. One is I want to know in what way can cataract causes glaucoma? 2 is during the cataract surgery, I understand it is important to keep the eyeball stationary. So what do you do if a patient is a bit not very sure that he can keep the eyeball stationary while the surgery is going on? The third question is, I understand this talk is about robotic cataract surgery, but so far I don't think I have heard anything about that. And those are my questions.
All right, let's come to your third question first. I can remember better your third question. Robotic surgery refers to computer-guided surgery. Computer-guided. So this is computer-guided surgery. It is robotic. It's just I like to use the word robotic. You like to use the word computer-guided. Fine. So it is a computer-guided cataract surgery.
So essentially, the laser operation is
robotic means computer-guided. It's not the robotic arms that is going to do surgery for you. Okay? So that's, I answered your third question. Your second question, again, if you don't mind, just repeat it. Okay. The best anesthesia, the best anesthesia is not injection, it's not eye drop anesthesia, it's vocal anesthesia. The surgeon talks to you during surgery. If you don't look straight up, the surgeon tells you, oh, Mr. Peter can just look straight up. We guide you during the surgery. When you lie down on the operation table, you'll be under the microscope, which has a light directly in front of your eye, all right? So we tell you, look at that light. So if you wonder, your eye starts to wander, we tell you, good, Peter, look at the light. We guide you. We don't give you general anesthesia or sedation, not necessary. In today's modern cataract surgery, it's not necessary. We talk to you, we guide you. And then you'll be surprised, within 15, 20 minutes, it's all done. First question. Glaucoma. All right. Let's talk about glaucoma. Now, when your cataract develops from when there is no cataract, when the cataract develops, it becomes thicker. All right? So it pushes your iris. Remember, the iris is in front of your cataract. As the cataract becomes more lumpy and bigger, it pushes the iris forward. And when the iris, the peripheral of the iris touches the cornea, it closes the drainage angle. That's how cataract can cause glaucoma, secondary glaucoma. Another pathology, how it occurs is that your lens actually is made up, the natural lens is made up of proteins. Now, when the cataract becomes mature, hyper-matured, these proteins leak through the capsule. All right? It leaks through. So the proteins of the lens should be enveloped within the front and back capsule of the lens. But when it leaks out of the capsule to the eye, this is foreign already. So it reacts, it responds by an inflammatory process which causes the rise in the pressure. Okay?
Okay, next question. Could we limit one question to a person, please? The gentleman at the back.
Thank you. My name is Yusuf. I am a diabetic patient. I'm due to do a cataract surgery on my left eye. But the right eye, it appears that it's just beginning developing the cataract. Well, if I do the left eye, and then it's whatever lens I put, multifocal, bifocal, this, I would love to do without glasses. But what happens? One eye, the right eye, still I need glasses, and the other one without glasses. So, how do you balance that?
Right.
Thank you.
Essentially, you are concerned about balancing, balance after your first eye has been operated. We always do the worst eye first. All right. If your diabetes has to be controlled first before the surgery is done, and once we implant, let's say a good quality multifocal lens, then what happens? That eye now can read, can see far, intermediate, near distance. The other eye is blurry, right? So depending on how imbalanced you feel, if you feel okay with the imbalance, you can manage, that's fine. There's nothing to do. But if you can't, and obviously you can't if your right eye needs to wear glasses, then if your diabetes is still well controlled, we recommend you to do the second eye too. Because you remember, the second eye also got cataract. And if you don't remove the second cataract, your daily lifestyle activities is being disturbed. Remember the dictum here, the indication for cataract surgery. If your daily lifestyle activities is disturbed, it's time for surgery. That's how we make decisions and help the patients make decisions. Thank you.
Hello. My name is Wong. I have two questions. One is, actually we talk a lot about mature, cataract mature. I would like to know what is the definition of this cataract mature. What do you mean by cataract mature? Number two, you see, when you go to have spectacle done, right? You have multifocal, you have the normal one. I somehow, among a percentage of people who have problem actually adjusting to multifocal, right? You tend to float and that kind of thing. So I actually give up and then go back to just a monofocal kind of thing. Now, with this cataract thing, right? Now you have put the thing inside there, right? Multifocal. Now, do you have a problem, or does the patient have a problem in adjusting, have difficulty in adjusting after having the operation with a multifocal? Just like you have a multifocal lens spectacle. Now, my third question is, it's quite related, right? It's quite related questions, right? Some doctors so-called recommend that right? You have one eye with a lens that you can see far, the other eye with a lens you can see near. So it's a compromised situation, right? So may I have your views on that? Thank you.
Yes. The third question refers to monovision effect, where you put monofocal lens and not multifocal lens, monofocal lens in both eyes, where your dominant eye, we aim for you to be 0 power, so that is for distance, but you can't read. And then your left eye, or the other eye, it may be right or left, depending which is your non-dominant eye, we aim for you to be short-sighted, say around minus 150 to minus 200, so that you can read, But you see, we don't function with one eye at a time. We always function both eyes, right? So we have to see far, we look with both eyes. Of course, we see near, we look with both eyes. We see with both eyes. Now, what happens is that when we drive, that's our distant vision, it won't be as crisp as if both eyes were corrected to 0 power. So now, at night, when you drive, you may have a problem. The sharpness is not there, and your confidence level will be affected. So if you want this technique, we also do that. But then at night, we will recommend you to wear glasses for driving, and you keep your glasses in a glove compartment of your car, so you can use it whenever the need arises. When suddenly it becomes dark, let's say now suddenly it starts pouring, it becomes dark. It's not yet night, but then it's dark, so you may need your glasses. Yeah, monovision technique is one way, but question is, can your brain accept monovision? Because there is an imbalance, there is a compromise. Can your brain compromise? Now, if you have been wearing contact lenses all your life, and once you hit 40 years old, your optometrist would still allow you to wear contact lenses, but they already do this monovision technique using your contact lenses, then you're all right, you can tolerate. But what if you never have used it before, and here it is, the doctor has placed monofocal lens in a monovision fashion for you, then what is going to happen? You already feel imbalanced. See? So, unlike implanting multifocal lens, we aim 0 power for each eye. So there's no question of imbalance in the refractive power. Now, Dr. Allen has told you that multifocal lens, the older generation is a bifocal, the newer generation is a trifocal. Multifocals are either bifocal or trifocal. The older generation bifocal, multifocal lens tend to give some problems, which here we stop using already. We use the trifocals. Yeah? Sorry, I think I way out. What was the first question? Bifocals? Yeah. No, some patients adapt well to bifocals, but some patients cannot adapt, So, but eventually the brain is very smart. You give it more time, it'll just adapt. Yeah, but then it is during that 1 year or so, or 6 months to 1 year, when you are not adapting, that's the time you'll be frustrated. You'll come and hassle your doctor, and he'll try to avoid you as much as he can, if he can. Yeah. Oh, another thing your question is, I think your second question, what was it? Yeah. If you put a multifocal lens, you say when you wear glasses, when you wear a multifocal glass, the patient actually has to look properly, from up to down along a very narrow corridor, on the glasses. And if he looks out of this narrow corridor on the glasses, he becomes distorted, his vision. This is glasses, okay? Glasses. But what we are implanting in your eye is not a glass. It's an intraocular lens, which doesn't function like a glass. So when we implant a multifocal, let's say a trifocal lens into your eye, if you want to see far, you just see far. You want to see near, you see near. There's no question moving your head or nodding your head. Yeah? Yes? So sorry. Yes. Yes. Okay, very good question. One eye implanted monofocal. Now his second eye, he has to make a decision. Is it a monofocal or multifocal? All right, second eye. My answer is this. If you really don't want to wear glasses, the second eye I will put a multifocal for the second eye. All right. But what about the other eye, which is a monofocal? Now today we have the technology where we don't remove your monofocal. We implant a second lens, which is a multifocal, into your monofocal eye. This is called piggyback lens placement. You know, is there somebody jumping on your back? It's called piggyback. Yeah. So this is what we do. For those who wants to convert their monofocal lens into a multifocal lens, the technology is available here in Malaysia. There are a lot of things we as refractive surgeons do. No, it's not dangerous. It's something, it's not just done 6 months ago. It's been on for many years in Europe already. Yes, there's a question there.
Ladies and gentlemen, raise your hands and our rowing mics will come over to you. One question at a time, yeah? Thank you.
Matured cataract, is it? Dr. Allen, you'd like to answer?
Matured cataract, I mean?
The definition of matured cataract according to what the patient wants.
Okay. When you come in, actually we do your vision check, okay? Before you see doctor, we'll know how good is your visions, okay? So 6/6 vision is the perfect visions. Okay, once your visions is dropped to like maybe 60 hand movement, counting fingers, and most probably you already have mature cataracts. And we actually look with a slit lens, our instrument, to look at the colors of the lens. Okay, so you can see just now Dr. Aloysius showed some picture. You can see the lens is actually mature cataract. You can see white color, even without an instrument. A lot of patients, they can look at the mirror, they can see their eye is white. And most of the time, we call it a mature cataracts. Okay, mature cataract is very hard cataracts, and most of the time, if you wait until mature cataracts, a lot of time you can't do a lot of modern cataract. You have to some patient with the mature cataract, you have to go through a traditional way where you need to cut it. You need to take more time, and actually you have more risk of complications. So we advise patient not to wait until your eye become mature. It's more a clinical assessment for mature cataracts.
I have done one eye with laser surgery, and I'm considering the second eye. My husband is. But after one eye, I find that my eye is very dry, and I always want to close my eyes. Always feel sleepy. I can't, especially when the sun is very bright and very hot. I feel my eyes very tired. I want to close it. But if it's like in spring or winter, I feel normal. Is that one of the side effects?
You mentioned you did laser. Is it what laser is it? You mentioned, is it LASIK or?
No, laser cataract.
With me.
Not with you. I did it overseas.
Oh, okay.
But I'm thinking of doing it here now. I'm having second thoughts. My husband also having second thoughts because of the side effects, you see.
Okay.
It's always dry and you want to close the eyes all the time.
Okay, now the thing is, now the issue is dry eyes here. Yeah? Cataract usually we do for patients who are senior, right? Yeah? Now, women actually, you all become menopause, right? And men become andropause with time, yeah? When a woman hits menopause age and post-menopause, they actually got dry eyes because of hormonal changes. Dry eyes, dry lips, dry skin, So you happen, at that time also we have to do cataract surgery, but here is more of management of your dry eyes. Yeah? Of course, that is hormone changes within your body, but if you are again exposed to a place with low humidity, your dry eyes become worse. In fact, the woman's dry eyes associated with menopause is 5 times worse than a man in andropause. You know, a man also got andropause. Yeah? Okay, yeah. So I think your case is more of management for dry eyes. Now here, dry eyes, of course, the gold standard is still using artificial tears. You know, but don't forget that dry eyes is now a global problem. It's not affecting only Malaysians. It's all over. In the US, it's finding it is a problem because it affects the productivity of the workers. You know? So it's not surprising to hear, if you travel outside Malaysia, to hear of what is called, even you go to Singapore, I'm telling you, you hear of things like dry eye clinics and all, I mean, in eye practices, you know, because it is a global problem. Just for your information, we will be starting our own dry eye clinic sometime this part of the year, this early part of the year. That would be another issue. I'm not trying to say things more, but it is a problem, dry eyes, which we have to address. It's not really occurring because of your cataract. You know, cataract doesn't really cause dry eyes. It's really an issue of your menopause. Why I'm saying this, you know, because there are some people, just because they have some form of eye surgery, anything they suffer from, it is that surgery that caused me. You know, it doesn't matter. You can tell that it is that surgery that caused me. No. You must not have that attitude. Yeah.
Okay. Doctor, I'm Leong here. Actually, you were talking about secondary glaucoma, and I'm having glaucoma, whether it's secondary or not. Then the doctor, they say I have a very little, only what you call cataracts. And they advise me not to do cataract operation. It may complicate my subsequent glaucoma, if necessary, surgical treatment. Could you kindly comment on this?
Okay. Actually, your glaucoma most probably is a primary glaucoma, where there's not due to any cataracts, okay, or not due to because of aging or other problem, okay. So the primary glaucoma, usually we use drop to control the pressure, okay. Nowadays, actually, cataract surgery also is one of the options to reduce your pressure. So most of the glaucoma surgeon nowadays will advise patients to actually do cataract surgery early, okay? By doing cataract surgery, you open out your drainage system. Your flow is better. Your pressure of your eyeball actually is controlled well. Even some patients, when they may need few eye drop before the cataract surgery to control the pressure, but after the cataract surgery, actually they reduce down the need of drops, okay? So this cataract surgery actually can help to reduce down your need of medication to control. And you see, cataract, if you wait until very serious, you will develop secondary cataract, secondary glaucoma. So if you have primary and secondary, definitely your condition will become worse. Okay? So most of the time now we advise patients to do early cataract surgery.
Perhaps I may just add, from what you described to us, you are actually having primary glaucoma. We call primary open-angle glaucoma, which is 80% of cases in clinical cases of glaucoma, 80%. You know, another one is the angle closure, primary angle closure glaucoma. But and then others is secondary glaucoma. Yours appear to sound like primary open-angle glaucoma. Most of the time, it is hereditary. Yeah. So we always come back to basics. Your parents, your brothers, sisters, do have glaucoma? No, I don't think so. No. They never come and check. Yeah. You have come, and I see your pressure is high. I tell you, hey, mister, you have glaucoma. But your brothers and sisters, they don't. They don't come and check, so you don't know. Now, primary angle closure primary open-angle glaucoma is what you have, as what Dr. Allen said. The first line of treatment is anti-glaucoma eye drops, right? And if we put one eye drop, then cannot control. We should start another second eye drop, third eye drop, fourth eye drop, still not well controlled. And we know the more eye drops we give to you, the less compliant you become. One day you remember, the other 2 days you forget, you know? So what happens? Then we go to the next stage, we do a laser treatment, or some glaucoma surgeons prefer to do glaucoma surgery. Because by doing glaucoma surgery, and they may combine with cataract surgery, glaucoma and cataract together to help you, to cut down on the number of eye drops required, so that you can become more compliant. Because glaucoma is the second commonest cause of blindness in Malaysia today.
Okay, we'll take the second question. The next question now, sir.
I had cataract surgery more than 20 years ago at Hussein Own Eye Hospital. My vision in reading is now blurred. I cannot read properly. I cannot see properly. I cannot recall whether it was the left or right eye. Anyway, I am now 76 years old. Doctor, my question is it risky if I were to take another surgery? I mean, is it dangerous?
Okay. You say you're 70-something, am I right? Did you say that? Your age? You're 70-something years old. How are you? 76. Okay. Now, remember, there are several causes of blindness. The number one cause is cataract, which you already removed, right? The second cause in Malaysia is glaucoma. Of course, we have to rule that out. The third commonest cause of blindness in Malaysia is the age-related macular degeneration. Mandarin is called Huang Pang Pu Ping Bian. That is, and you are 76. We have to check you to determine what is causing you to have failing vision. In age-related macular degeneration, it affects the macula, which is the part of the eye for reading. And now you are telling me that you have difficulty reading. For all you know, you are suffering from that. So we have to check you to be certain what you are suffering from. There's no shortcut, You need to be properly checked. Yeah.
Okay, next question. Can we have the gentleman in the back, please?
No, we check you first because we check you first.
Sir?
Doctor, thank you very much. I have been wearing specs since 20-something. So lately, I went to see the doctor. The doctor told me that I have cataract. And I'm not sure when should I go for the surgery, because if I'm wearing my glasses, the vision is okay. But of course, when you take off your glasses, it's not good. I don't know whether you call it blurry or whatever. If you have been wearing glasses, the moment you take it off, the vision definitely is blurry. So when do I go for my operation?
Dr. Allen.
Okay. I think the most important part, do you want to be spectacle free or not? Do you want to have a better vision? Okay, once you have cataract, definitely your vision will slowly deteriorating and slowly will affect your lifestyle. Okay, your hobby, you can affect your daily activities. Okay, so most of the time nowadays we actually not only taking out your cataracts. Okay, like you say you have to wear glasses since you are young. Most probably it's short-sightedness. You can't see far. You need to depend on glasses. So young people nowadays, they can do LASIK to correct the short-sightedness. Okay, but for your age also, we can actually help you, especially if you already have cataract. Why we want to wait until the cataract become worse? You can do any time at this. Okay, with the modern surgery, which take about 10 to 15 minutes, painless, okay, straight away after the surgery, the next day you actually can drive without glasses, you can read your book, use your computer without glasses. So my advice is, if you're really willing to take away your glasses, no need to wait, okay? You can come to us and we can give you more guidance, information, and you can do anytime, and it's very safe procedure nowadays, okay?
Okay, the next question, gentleman at the back.
My name is Sang Chiu. Just want to ask a question that the choice of, you have said it earlier, but you're not very clear. The choice of choosing the lenses. There are people who prefer to use lens which you can see far, and then use glasses to read. And they say this sort of vision is far more superior than the multifocus or trifocus. Is that correct?
Okay.
And my second question, after this lens replacement, is there any post-operation maintenance management required? I have multifocal lens replacement for both eyes. It was very clear, very nice, super, for 3 months. After the 3rd month, vision seems to be deteriorating under warm light. And every time I need a fluorescent light to read. And sometimes in the restaurant, when the print is too small, I still cannot see. So is multifocal lens not as superior as compared to monofocal lens?
Okay.
Thank you.
Okay. I think you did your surgery how long ago? Your multifocal? 10 years? 5 years? 10 years? Okay. Okay, I told you the older versions of multifocal lens is mainly a bifocal lens. Okay, bifocal lens is only help you to see far and near. And actually they have the quality of the image not as good as the monofocals, okay? Mean that the contrast is not good. You need actually good lighting. Only you can see better. Okay, that is about the older versions. So now the technology already evolved and become better. And nowadays with the trifocals, actually it's actually give as good as the monofocal. Okay, so you have to choose what type of the lens, because still a lot of doctors still using the older versions of multifocal lens. So you have to know what type of lens you're using. If you use the older multifocal lens, the bifocal lens, definitely the monofocal is better quality for distance. Okay?
Sir?
Okay, I say the newer version now is very good for all distance, all range of distance. Their quality of the light, because in multifocal actually there's some loss of light, especially for the bifocals. But for the newer one, it's less loss of light. Actually, a lot of study compare the mono and the trifocals. So after you implant the trifocals, the quality compared with the monofocal is actually the same.
Okay, next question to the lady in red.
My name is Kim. I would like to know what can we do to improve our eyesight before all this, as we age. You know, they say take carrots, goji berries, and eye exercise. Can you enlighten us on this? Thank you.
Nutritional supplements. Nutritional supplements that are good for the eye are the antioxidants, like lutein, zeaxanthin, vitamin A, C, and E, and these bilberry extracts like acanthocyanosin. These are antioxidants. Like I said, antioxidants are good in the for the general health of the eye. Plus, it helps to sequester free radicals. Free radicals are the ones that is present in our food, radiation that bombards the cells in our lens and cause it to age. These antioxidants tends to sequester or eat them up, so that's why I say it sort of slow down your cataractus process. Yeah, as these are nutritional supplements. But what about natural food? Yeah, the more green vegetables or green fruits that you take, the better, because they also got antioxidants. Yeah, of course. I got one patient who told me that I don't like to take nutritional supplements. I only want natural food. I said, yeah, that's true. But then you have to take kilos and kilos of vegetables and fruits and to attain that dosage. Obviously, we can't. That's why we need nutritional supplements at the same time. Eye exercise is age-old, you know. When I was a young man, people are talking about you want to remove your glasses, you can do eye exercises. And it never happened to me. I had to do LASIK. Or rather, my mentor did LASIK for me 19 years ago.
Thank you very much. How about some questions from this room here? The gentleman at the back.
Hello. Good morning, doctor. My name is Patrick. I'm diagnosed with cataract on my left eye. Now, when I close my right eye, I can only see the white screen, and the Q&A session I cannot see. So I went to the Hussein On Hospital, and it was confirmed that there's a cataract. So I searched through the internet, and I found that there is one product, Can-C. It contains what they call N-acetylcarnosine. And from what I read in this product, it says if you try this product, and after 6 months, there is a 99% chance of improvement. I would like your advice.
Yeah, this product is an eye drop.
Yep.
You know?
It's called Can-C.
There's one company that is trying to promote this product. Actually, what you mentioned, actually that is an antioxidant. You know, they have done some studies somewhere in Russia, all right, and that study says that I can stop cataract. Then I corrected the guy who came and see me. You know, from the company, you show me the studies. You say can reverse cataract. Show me. You know, it's not. It's they are talking about 6 months later. You know, you don't see progression of the cataract. Yes, as I told you, antioxidant does slow down the cataract process, but it cannot reverse your cataract. If you got cataract, it's not going to disappear with this eye drop. Perhaps you pour gallons and gallons inside, you still won't disappear, you know, except that you suffer from the toxicity of the eye drops. It doesn't work that way, you know. You need, if cataract, you need cataract surgery. There's no escape. This is centuries. You know?
Okay, next question from this side of the room. The lady up front.
Hi, my name is Ailan. I wanted to know if you would recommend such a surgery on a 90-year-old patient who is hypertensive. All
right. Cataract occurs in senior citizens, right? Whether they are in the 80s or 90s, if they want to have a better life, better vision, and they are physically or surgically fit. Yeah, you say they have hypertension, but if the hypertension is well controlled, then they are surgically fit. They can have the surgery. There's no reason not to give them good eyesight just because they are 90 years old and have hypertension. 90 years old with good control, yes, you can have surgery. Yes, it's not very high, yeah. But many old folks at 90 years old, some patients they give up. You know, they say, "I'm happy. It's okay. It's okay. I can whatever I can." They are not blind, yeah. I'm saying they are not blind. The cataract has impaired their vision, but they are quite content to not to do anything. Because, oh, I'm 90 years old already. How many more years I got to live? You know, that type of attitude they have. So we don't try to talk them into surgery. That's why I told you, you never try to talk patient into surgery. If that's what they want, we give them the proper advice. If that's what they want, then that's what they want. Then one day they'll come with secondary glaucoma, with red eyes and painful eyes, and they admit in the hospital, and then they have to have the surgery. Whether they like it or not, it's just a bad tooth. They don't want to remove it. You can't sleep. Imagine the eye throbbing away in pain. So they subject themselves to cataract surgery at that time, but it's a lost cause because the eye is blind.
Okay, thank you, Doctor. The next question, please. This is down to the last two questions.
And everyone, in fact, I have a by the way question. In fact, one of the causes of impairments in eyesight, it seems to be floaters in the eyes. Can you let us know, is there any treatment for such a symptom?
Alan? Floaters.
You talk about floaters? Yeah, floaters is actually aging process where our eye, the eyeballs, is actually filled with gel. We call the vitreous. Okay, the vitreous when we are young is clear and solid, but when we are aging, the gel starts to become liquefied, and sometimes when you liquefy, you start form some opacity, and the opacity is actually can move, float around. So, and if the opacity is blocking the light, and you can see the floater, and most of the time, this floater, 90% of this floater, we call it physiological floater, and it's harmless. Usually, we no need to treat it, and it will disappear by itself. Some, maybe about 5 to 10% of the floater is due to bleeding, okay, sudden bleeding because of, can be any problem, can be due to aging, can be due to diabetes, or you may develop some nerve problem we call the retinal tear, retinal hole, and then that is serious. The floater we have to treat the underlying causes to prevent further complications. So most of the time, the floater, if you just see one or two, usually we advise patient not to worry. Okay, it won't disturb you, and it will disappear by itself without any treatment. Unless suddenly you wake up, you see multiple floater, or you see some blockage of vision or shadowing, then you need to see eye doctor immediately and to find out what is the underlying problem. Okay.
Thank you, Doctor. We'll take two more questions. So, to the lady up front, please.
Good afternoon, doctors. My name is Ms. Low. Now, we have looked at your robotic operation on cataract. What I'm concerned about the cost now, as opposed to the normal cataract operation, and the tricycle lens that you mentioned, is it also referring the same meaning as toric lens? Thank you.
No, okay, I'll answer you. A toric lens, we have trifocals that are toric and trifocals that are non-toric. Toric, the word toric means the lens itself correct your astigmatism, if you happen to have astigmatism. The non-toric lens means that lens doesn't correct astigmatism, it just corrects your short-sightedness or your long-sighted, whatever, but not your astigmatism. That's the meaning of toricity. Yeah. Now, your first question about this cost, yes. You know, I've been asked to speak about this femto cataract surgery, the pros and the cons. You know, and I can tell you one thing: the biggest con of all cons, if there's such a term in femto cataract surgery, is the high cost because it's technology. For the past 7 years, we introduced this femto cataract surgery 7 years ago. We have been fighting with the vendors, the suppliers, you know. And then finally last year we managed to bring down the cost, you know, but it's still a cost. We can't help it. You know. I wish there's no cost to it. You know. How much more is it? Yeah, it's about 1,000. How much? Where's Chloe? 2,000. Oh, it's a 1998. It's about 2,000 more per eye. Per eye. 1998 now. 998 was the introduction. Yeah. What is that? She's having. Oh, is that one? No, it's talking about this one. Is without. Is that with the? No, that's the blade. That's the blade. You are talking about additional the robotic. This is the blade. 199 is the blade. I think my marketing people can explain better to you, because I'm not really involved in this costing.
Ladies and gentlemen, if you have any inquiries in regards to prices, you can go on outside later after the talk to the counters, and we have people to assist you there. We'll take one last question to the gentleman at the back. Sir, we'll take your questions in regards to prices outside of the hall.
Okay, my name is Fu. Thank you very much, doctor. I would like to ask the trifocal lens question. If I can read comfortably without lens at the near distance, so do I still need a trifocal or bifocal or monofocal?
Okay, very simple. Because you take out your glass, you have short-sightedness, correct or not? Okay, so you got short-sightedness. When you take out your glasses, you can't see far. You can bring near, you can see actually very, very near. Okay? This is short-sightedness vision. Okay? Your vision is just limited to near. Okay, but once we do a cataract surgery, okay, our vision will return to normal vision, where if you put a mono, you will just only see far. You will lose the near vision. Okay? You cannot gain back the near visions. Okay? You must understand that. Okay? Because we already corrected your short-sightedness. You don't have short-sightedness now. You can't read near. Okay? So you need a trifocal for you to see all range of vision. Okay?
Okay, thank you very much, doctors. That's all the questions that we're taking for today. Let's give our speakers a big round of applause. Thank you, doctors. That's the conclusion of today's event. We hope that today's talk will help you understand that cataract really shouldn't limit your lifestyle, and be sure to go for regular eye checkups. Ladies and gentlemen, also if you're interested to get your eyes screened by doctors from Vista Eye Specialist, you'll be able to do so for free at their upcoming carnivals. 9 to 11 March at VJ Pista, at VJPJ, Puchong and Bukit Mentajam. 16 to 18 March at Vista Klang, Johor Bahru and Aitam. Also, don't forget to head on outside to see one of our Vista consultants to book a free consultation with one of the doctors during their carnival. And with that, we come to the end of today's StarLIVE session. Do remember to collect your goodie bag before you leave.